So welcome. Thank you for stopping by after lunch and joining us for an important discussion on diversity, equity, and inclusion. As you may know, VAS has made this a priority topic for several years now and has hosted keynotes and workshops with Dr. Mercedes Avila, and we're very privileged today to have two of her colleagues join us to continue the conversation. Guadalupe Martinez is a Mexican-American millennial who immigrated from Sonora, Mexico to Arizona with her family at a young age. Thankfully, because of her DACA status, she received her Master of Healthcare Administration from the University of Arizona in the spring of 2022. Her lived experiences of food adversity, housing instability, and health disparities propelled her to become a DEI professional in 2018 at Banner Health, a large integrated health system, where she had the opportunity to be one of the founders of their diversity and inclusion department. Guadalupe joined the University of Vermont Health Network as their first network diversity director in March of 2022. In her short time with the network, Guadalupe has delivered DEI and LGBTQIA+ care training to leadership at multiple hospitals and agencies, is spearheading policies aimed at creating more equitable processes for staff, patients, and communities alike, and is collaborating with key network partners to identify DEI metrics and data, which is my bread and butter. That's pretty exciting. Erin Armstrong grew up in Vermont and graduated from St. Michael's College in 2000. After completing 2 years of AmeriCorps Vista and working in alternative schools locally, she attended Bryn Mawr College Graduate School of Social Work. Her early career as a social worker brought her to the Boston area, providing direct service to children and adults from marginalized communities, and later back to Vermont to Northwestern Counseling and Support Services, where she led a case management program and a therapeutic community residence for individuals experiencing severe and persistent mental illness for 9 years. In the last 5+ years at the UVM Medical Center, she has held a variety of leadership positions that focus on connecting people to the care they need, and later shifted her focus to address the upstream factors that lead to some of the inequities that many people experience. Recently, Erin was promoted to the Network Director of Community Health Improvement for the UVM Health Network to help lead the strategic alignment of diversity, equity, and inclusivity strategies with the community-facing health equity initiatives. As a social worker and a white person on a lifelong journey to be anti-racist, she feels humbled and honored to work among a team of talented professionals and to be able to listen and learn from the community in an effort to make it a more equitable and thriving place for everyone. Please join me in welcoming Guadalupe and Erin.
So what is diversity? Diversity is any dimension that can be used to differentiate groups, right? If you go into Google, you'll probably find hundreds of diversity definitions. What we like to point out of this large diversity definition is that it includes respect for the appreciation and similarities of our differences. So what does that mean? What you see besides you, it's right here, it's a diversity wheel, right? And it's a framework for thinking about how does diversity show up in our institution and as individuals. And what we like to say is this diversity wheel, it's broken down to 4 layers of diversity. The first layer is our core dimension. It's our identity and our thinking style. It's how you communicate and who you are as an individual. The primary internal that you see where it shows national origin, gender identity, ethnicity, sexual orientation, mental and physical ability, age, race, and all of those, that's your primary, right? And that's your primary. So your primary has an effect on how you interact with other folks. It has an effect on, what you say, what you do, your behaviors, your attitudes. Then you have your secondary. Your secondary is it can be relationship, geography, meaning where you live, etc. So those are the differences that we acquire based on connections to our environment, social, cultural factors, and experiences. And then in the last piece of that diversity wheel, you have your organizational and your cultural dimensions of diversity. And those are largely defined by the group or the workplace in which you are part of. That has a big influence on who you are and how you interact on the everyday basis. Now, the reason why I really wanted to set precedent for diversity and what it means in this diversity wheel is because a lot of times people think of diversity and automatically race, gender. When in reality, we know there's a lot more than that, right? There's experiences, your thinking style, your parents, who your friend group is. All of that has a large, influence as to who you are. Even generational. I think a big piece that we often miss as, we're going through this journey of DEI is the generations and how they interact with one another. Thinking about Gen Zs. So according to a study by LinkedIn, Gen Z will be 30% of the workforce by 2030. That's only 7 years away. And Gen Zers are anyone who's currently younger than 25, so anyone born from 1997 to 2012. So think about that. And according to that same study, 78% of them said that they have DEI at the forefront. So more than pay, they're willing to leave a job if it doesn't satisfy them, if they don't feel included, welcomed, heard, valued, respected. So those are the things that we have to think about as we're going through this journey. When you think about retention, turnover, I want you all to think, how is it that we're retaining maybe different generations, not just for race and ethnicity and for sexual orientation, gender identity, but our generations and how they operate, how they communicate, their, what they want from the workforce, flexible working style, more PTO, et cetera, good work-life balance. All of those things play a factor into it. And then before I move on into inclusion, which it's vital, and we've learned it's vital as we've gone through this DI journey for decades for some folks, we want to touch base on intersectionality. And the reason I bring up intersectionality, it's because a lot of times we forget that as humans we are complex. And so what does that mean? That means intersectionality itself, it's the complex cumulative way in which affects multiple forms of discrimination because a person holds multiple identities. So for myself, I'm Mexican, I'm a woman, I'm a millennial, I'm a mother, the list goes on. And all of those identities combined affect perhaps either the barriers that I have or the ways in which I interact with every individual. So something I want to point out that's stated from, University of Michigan. So I want to point out a data stat that I thought was really, really interesting. It said, while only 21% of corporate leaders in the US are women, only 4% of those corporate leaders are women of color, and only 1% are Black women. So if you think about intersectionality, I don't want to say it's another barrier to get to the same outcome as everyone else. However, we have to understand that the more intersectional experiences and identities that you hold, perhaps the more barriers and challenges that you have to face. So I wanted to bring the intersectionality piece because I'm sure within your workspaces, who you connect with, there's intersectional experiences that show up each and every day. And then they affect the kind of outcomes that we have for folks. So when moving on from intersectionality, I wanted to go back to inclusion. We know that diversity is great to have within the workforce, diversity in a multitude of ways, right? Not just race and sexual orientation, gender identity, but inclusion. And with inclusion, I wanted to show you this multi-level analytical framework. Building an inclusive culture and an inclusive environment, it ensures equitable access to resources and opportunities for individuals, right? And what you see here, it's this really cool visual as well. As you can tell here at the network, we like visuals. So it's this cool visual, but it shows the way in which inclusion has to exist. The first piece being society, so within our state. What are we doing within our state to build an inclusive, system, inclusive state, whether that's LGBTQIA plus policies, whether that's accessibility policies, language access, and so forth. Within the organization, thinking about inclusive policies, practices, and then the processes that we do each and every day. At the network, just to give you a little bit of a kind of an idea, what we're doing is we're working on some network policies for microaggressive and bias episodes from patients to colleagues to our nurses, our staff in general. So what does that look like? How do they respond to it? Nobody should have to come to work and have to deal with being called so-and-so, the N-word, et cetera. Those kind of things happen. And that's apart from workplace violence. A lot of time we think workplace violence, physical violence is the only kind of violence that exists, but we have to understand the emotional toll that microaggressions and biases play on an individual and them staying at a place. So talking about policies and processes, and then even how do we implement that? Making sure that the implementations of these policies are equitable across the network, that it reaches all of our staff, not just our nursing and clinical, but our EVS, and so forth. And then with leaders, talking about inclusive practices. If you're a leader right now, right, and in any form really, how are you ensuring that you're calling out microaggressions and biases when they happen? Biases meaning those behaviors that impact how you build relationships with others, right? And that might be based on previous experiences and so forth. So thinking about what inclusive practices you're taking on place. So not only calling out biases and microaggressions, but in addition to that, thinking about your hiring efforts, succession planning, who is getting promoted, who is getting mentored. Are you giving an opportunity to the person that you usually wouldn't think about? Are you selecting somebody to be hired because you have this bias, this for them bias because they went to the same school as you? Perhaps they grew up in the same neighborhood. Perhaps, you guys went to the same church. Who knows, right? But thinking about all of those little pieces that have an effect into what our workforce looks like. And then within teams, once you set that expectation for teams to practice inclusivity, for leaders to practice inclusivity, the teams will follow through. And then the expectation of the individual is that you are looking at the lens of DEI in everything and anything you do at all times. So with that being said, I just want to touch quick base on this one quickly, and I won't spend too much time. Belonging. In order to have a culture of belonging, we need to remember that we have to have a diverse workforce that looks very different for everyone, that's included in their policies and practices, who's getting promoted, who's getting hired, etc. And then equitable processes along the way. Wanted to touch base on how do we do that? A lot of organizations, and in general, I think as a nation, we're operating in the equality space, meaning we're shooting and we're aiming to provide everyone the same resources and expecting them to reach the same level of outcome or opportunities without realizing that individuals have face different disparities, are affected by different disparities, have different challenges and opportunities within their own lives based on them being part of a marginalized group, such as a person of color, BIPOC, being part of the LGBTQ, accessibility, so having a differing ability. And when we start giving everyone the same resources and expecting an equal outcome, you're not gonna get that, because then you're not looking at the individual for the individual. Within equity, then we start looking at, okay, so we're understanding different marginalized communities have different barriers to care, have different barriers to being hired, education, etc. So then we start allocating resources appropriately to each person to meet the need of whatever barrier that's affecting them. And then in justice, well, that's going to be more long-term, right? And that's where we dream of being, but that's at that point where we're removing systematic barriers in order to go ahead and have an equitable community, a nation, organization, etc. So I wanted to touch base on shifting the focus a little bit. So we set the stage for having shared language and understanding of diversity, equity, inclusion. I want to go ahead and touch base on the work that we're doing now at the network and share a little bit more about that to give you some insight. Maybe you can relate in your organization, or maybe we're doing something and you want to do the same thing. But I want to show you how kind of we got there, right? So we took a step back and we assessed where we are, and we looked at DEI as a journey. Because DEI is a marathon, not a sprint, and we have to remember that. It's a continuous pathway that we have to go through. So in the past, in the 60s, DEI emerged, and it emerged out of anti-discrimination policies, right? And then in moving to the present, DEI became more about inclusion. It became further than just a checklist, right? But in the past, it used to be all about checklists, meeting certain requirements, et cetera. Then it moved into the idea of inclusion and how do you adapt to respond to the changing, transforming workforce. And then in the future, currently where we are in future state, DEI is going to go beyond just being education and being an advocate, right, for different folks. Instead, it's going to be integrated into the organization, data DEI-driven decisions, and really being part of the strategy, as it should have been a long time ago. So, wanted to go ahead and move along to our roadmap to kind of show you and be very transparent as to where we are with the network. At times it might feel like, as an organization, or even your organizations, you might feel like you're moving a little slow, right? and you're like, we need to do this, we need to help certain groups, we need to do X, Y, and Z, better hiring efforts. Our suggestion is that we must slow down and really consider, between what we know, what we think, and stop guessing about our communities, and instead start serving our communities for the needs that they have. Start serving our employees for the needs that they have. So what you see in front of you, it's kind of like a roadmap. And this shows the journey that we're currently in. So starting with where we are, what we did in the beginning of 2022 or so, we partnered with Jeffords Institute Quality Project Manager. She's amazing. And she, her along with our SVP of DEI, they did a gap analysis. A gap analysis to help identify the areas of opportunities that we have in terms of DEI. So maybe DEI with HR, DEI meaning in our hiring practices, DEI for promotion, DEI in succession planning. Are we thinking about diverse, workforce when we're trying to promote folks? So all of these areas, IT, policy, government, etc., all of those areas. So a thorough gap analysis based on best practices was done. Afterwards, we established a foundation based on best practices nationally and with our data. And then currently where we are, we've established that gap analysis, we've established what gap opportunities we have, right? And now we're establishing partnerships. And the establishing partnerships, it's really a lot about teaching our leadership the areas of opportunities that we have and bringing them along. A big part of DEI is having your leadership at the forefront, leading this work, saying, hey, if I'm the leader for HR, what can I do differently? If I'm leading, IT and there's some gaps there for Epic, whatever, Cerner, whatever system you use, what is gonna be different there? Afterwards, we're gonna go ahead and take action that's accountable to senior leaders, right? Ensure that there's KPIs, ensure that there's metrics that meet the need of those areas of opportunities that we have. And then we go into assessment, meaning assessing where we are with those KPIs and metrics, sustainability of those KPIs and metrics. It can't be a one and done. And then afterwards, we do the same thing all over. It might be a 3-5 year plan. It might be a little longer for some of the things that we're looking at, but we just have to be realistic and intentional and hold leaders accountable as well. So another thing just wanted to share for the DEI strategy, and this is what came out of that gap analysis, those areas of opportunities. So what we're focusing on right now is our patients, families, our people, and our communities. And we're working on some great strategic KPIs, metrics, et cetera, that are coming out of this strategy right here. And that's more tactical and based on the communities that we're serving. Some other things we're working on is, just want to give you a overview where we are. So we partner with our data management office and really built a foundational, vision for what we want to focus on in terms of health equity, quality metrics, that are affected by social determinants of health. So we're going to be looking at some inpatient and ambulatory quality metrics that are connected to common social determinants of health, such as multiple dimensions of diversity, and let's say breast cancer screening for Black African American populations, right? We know there's a disparity there. How do we start looking at the data? Where is it happening? How do we start educating physicians, et cetera? If it needs to change. So these are just like just an overview of where we are and where we're headed. We also took a look at our staff. And so we worked with our IT team, with our human resources team. They were phenomenal. And we said, okay, so what data do we have accessible for our employees? We're missing, let's say, sexual orientation, gender identity, identifications of our employees. And if we need to change something within the workforce and we're not aware of how do they identify, what identities are important to them, how do we start changing that narrative, right? And in order to do that, what we did, we went back, we updated our own system that captures the identities of our workforce, and we added gender identities that are up-to-date sexual orientation, race, ethnicity, etc. And currently we are about to launch a campaign so our workforce feels comfortable enough to share that information that's stored in a secured place, not going to be shared out with everybody, but then it starts giving us a picture of who our workforce is, what do they look like, what our generations look like, etc. And last but not least, out of this work that we're doing, is sexual orientation and gender identity for SOGI. So we realized, and I'll say we, but as the network started this journey back in fall of 2019 at UVMMC, and their purpose was really, how do we ensure that we're accounting for the 7% of LGBTQIA Vermonters that we have in the system, plus those that we serve in the North County, New York, and making sure that our patients feel safe in disclosing who they are, and they have a way to disclose who they are through pronouns, through sexual orientation, gender identity, sex assigned at birth, to make sure that we have all their health history in place. So we started that journey back in 2019, and since then it's been phased out to our other communities besides UVMMC. And then last but not least, some things that we're doing across the network to cultivate DEI. We're working on some really targeted education across the network. So we have done DEI trainings for almost all of the leaders across the network. We are working on Safe Zone training and bringing a Train the Trainer for Safe Zone, meaning the LGBTQI Health 101 class, into the network. We're also working on some equitable items, meaning partnering with our data management office, as you can see, for those quality metrics, working on some language access and standardizing that across the network to make it easy for anyone to get an interpreter that's needed, accessibility for those that are hard of hearing, etc. And then working on community benefits, which my colleague Erin Armstrong will talk a little bit more in a minute. So that's it. Thank you so much.
So thank you, Guadalupe. That was a lot of great information. And my hope for this next portion of the presentation is that we can really sort of take some of those fundamental concepts and think about how we can apply them within our own teams, departments, organizations, all of our spheres of influence. So as we think about population health and health equity, there's many different reasons of why we should be focusing our attention there. And here are a snapshot of the top three, right? In the healthcare business, we know that people experience health disparities at a higher rate than certain key populations. We know that good care to everybody is a part of the triple aim. And as healthcare institutions, employers, neighbors, community partners, that with those roles brings us power and the ability to really influence the systems in which we operate. So when we think about that image of the park, right, the three different what equality, equity, and justice look like, I really liked these definitions, and I think about that image. And it's really about moving to a place of health equity and ultimately the end goal being health justice, right, where health equity is about kind of how do we develop the workarounds, how do we eliminate some of those barriers to for the individual's experience when they're trying to access, the same care or to access care. It's really, health justice is really thinking about the future when those barriers do not exist. So the actions that we can take now in a coordinated fashion will eventually build on the systemic changes that will come in the future. So we're going to dive into 6 key areas of focus and really start to talk about where to apply these different ideas. And really what we're going to do is reflect on a series of questions, because I think, as we're all on this journey of learning about health equity, it's, I think asking ourselves questions is really a good starting place on, how do we think about things? Where do we go from here? And so we're going to do some small group activities and some large group activities, just get people thinking and reflecting so that we can start to really think about some tangible things and leave here with some concrete ideas of where do we focus our efforts next? Because this work is big and it's going to be ongoing, and there's so much, to do at this point. And we can work with consultants and things like that and go on this journey. But really, I think a lot of it starts with sort of reflecting on our own selves and our own privilege and how we can think about things in a really different way to make a positive change for everybody in the community. So the first section we're going to focus on is culturally appropriate patient care. And so even if you're not directly a provider, I'm sure that everybody's had an experience within healthcare where they can think about, what that might look like if they, were seeking care, and, how does a cultural competent and cultural humility, what does that look like in action? And how are other people's beliefs and identities and behaviors that they engage in, how are those incorporated into a visit at one of the organizations? And then also we're going to reflect on what sorts of things would you need in your organization to really start to shape that and to move it forward in a meaningful way. So we can talk about it and have the ideas, but what's going to keep it moving forward? So I'd like to take maybe 5 minutes to work in at your tables and just start to think about these 3 questions, and then we'll just share some of our ideas after. Let's start with the first one. So thinking about what is cultural competency, what is cultural humility, what does that look like in action? I heard you all talking, so I know somebody's got something to say. Yeah, great.
So I am a provider, I'm a physician, but I'm also a dad to a kiddo who has autism. And if I get emotional, I apologize. To me, it's about comfort. So when my kid goes somewhere and receives care at an office, at a medical appointment or something of that nature, he's not sitting quietly by himself. He's loud at times, and it's your fault, Claudio. No, it's fine. You get looks, you get sneers, you get comments that you overhear, and there's other places that run things very differently where you feel comfortable. You can go there, you can let your guard down. Your kid can get the care that he needs. Without that stuff, I apologize. This usually gets me very emotional, but that's what it looks like to me. It's about feeling comfortable receiving the care that you need. And when I'm delivering care in the hospital, I'm a hospitalist, I see it all the time as well with my patients where they may experience different inequities or people treating them in ways other than what we want to. And when you can connect with them on a personal level and they tell you, hey, I have felt very differently in the experience I had before, and I thank you for meeting me where I'm at. But to me, it's about comfort. You need to feel comfortable in receiving the same care that we all should be receiving in whatever venue that is. I'm sorry.
Thank you so much.
Thank you.
Thank you.
Yeah.
This wasn't said at our table, but the theme I'm hearing, what's coming to mind in all 3 stories I've heard is that's the difference between the golden rule of treat other people how you want to be treated. The platinum rule I think is better, that you're treating other people the way they want to be treated, which takes more work to find out what is going to make you comfortable, whether you're a staff person who's got a more diverse workplace happening, or you're a patient who's experiencing that kind of discrimination, or whatever. So that's a humility piece of, oh wait, my culture is my culture. It's not necessarily the norm, or even if it is more normal and more popular or familiar, it's not the only one, and I don't know how to respond to everyone based on what I was raised with. So that's the piece I get.
Yeah, absolutely.
Thank you.
Yeah, I love that. Yeah, that is really speaking to the humility piece. Like, where is our curiosity? Where is our own self-reflection of who we are, and recognizing that who we are really shapes the lens in which the way that we view everybody else, and just being curious and non-judgmental and really wanting to, understand what makes them comfortable. Yeah, I love that. Thank you.
I think also taking ownership of your learnings about it and not always using like the diverse people in your life to learn about something is more taking it upon yourself to learn about it, because the people coming to seek care from you are just trying to seek care. They're not trying to help you understand more about the population they're from. So it's nice also if you do some of your own learning on your own time for groups that you're not in. So, and we're all not part of some groups, so there's always something everyone can learn.
Yeah, absolutely. Yeah. Yep. Yeah.
I just want to add that as healthcare leaders, also to understand where is it that our staff in our community are in that cultural competence. I had an experience when I was working at another health system in which we brought nurses from the Philippines, and what we found was that the patients definitely were not ready to have nurses from another country. The community was not ready, and our staff definitely was not ready, as well as our system on how to manage not only the expectations, but also manage people from another country with very different customs than our own. So had to do a lot of in the moment learning and shifting of what is it that we always do to how is it that we can meet their needs and the needs of our patients.
One of the things that I get to do is to work as a contracted peer reviewer for the American Nurses Credentialing Center, which is the organization that makes decisions about whether a hospital is a magnet designated hospital. And one of the standards that the magnet hospitals have to reach is to provide an example of culturally competent care in action. So it kind of covers all three questions. And recently I surveyed an organization that told this incredible story about taking care of a patient who was a very had a very strict Jewish religious background. I think it was Orthodox Jewish background. And so there are a lot of cultural rituals there, a lot of dietary rituals, and it was in the middle of the very high holy days. And this patient was a patient in their hospital. And they wanted very much to take care of this patient in an appropriate way, but most of them had no idea of what all of these traditions were. And so they reached out to local rabbis and a local group to learn more about what they didn't know in order to make a plan of care for this patient that was going to be culturally competent and culturally sensitive. And it was just amazing to see what they did. One of the examples is during this holiday, the people are not supposed to use mechanical things like even computers or drive cars and that kind of stuff. And so the staff went out of their way to make sure that they found other ways for the family to get to the room instead of the elevator, and used some paper charting rather than dragging the computers in. It was just an amazing example of how they went out of their way to be sensitive to this culture by using the expertise that they could garner from others in the community and some of it from the family themselves. So it's just kind of takes all of those pieces and kind of puts it together into an amazing story. So I just shared that.
Thank you. That's a great example. Thank you. I love that. Yeah.
So a lot of dermatological conditions appear differently on darker skin. And so the health network and the medical students at UVM, they've been using a tool called Visual DX for many years. And just recently, Dr. Levine is providing the software to every clinician across the state of Vermont, so that if someone comes into your ED or room that you don't typically see of someone of that pigment, you can use this tool with just 40,000 images, and you can try and figure it out and catch something earlier, because oftentimes in darker skin, things are caught much later, which makes the mortality a lot higher. So if you have any questions about it, sounds like a self-plug, but I really promise it's not. Dr. Levine is covering it, the Department of Health is covering it, and we just want to provide the same tool to everyone. So.
Thank you for sharing.
Great. So when we think about accountability structures and how do we keep people engaged in this journey, providers and everybody really at our organizations, what do you see as working for keeping people on the path, on the journey of becoming a culturally competent organization person, having cultural humility, which is an ongoing, lifelong journey as well. What are some of the things we talked? I know Guadalupe mentioned earlier in your part that sometimes some DEI goals or health equity goals are tied to sort of leadership performance evaluations. Everybody has sort of a formal professional goal that is to carry some of this work forward in what they do, and are evaluated. They're evaluated on that on an annual basis about the progress towards that. Moving through the organization. Is one way, but what are some other ways? Yeah.
I just think it's important for hospitals and their communities to recognize the power that they have in their community, and the fact that in Rowland, for example, it's the largest employer in the county. Mm-hmm. So making statements about Black Lives Matter, or where we see everyone, has like a ripple effect within the community to say, hey, this is how it should be. It sets a norm, and I think that's really important.
Yeah. Absolutely. Yeah. Organizations being large definitely has the power to influence systems in a much bigger way. Yeah, Carolyn.
I think accountability actually starts with the individual. And organizations have to create a zero tolerance policy for bystanders, people who see microaggressions and don't call them out for it. And I think there's more of that than we actually want to admit. And I think the first step is saying, this is how you do it, some cognitive rehearsal on how to bring it up to someone. Gee, I saw this interaction, and I'd like to talk to you about it. Because most people find the easy way is just turn your head and not say anything. So I think it really begins at the individual, and we have to, as leaders, have to teach them how to do that.
Thank you, Carol.
Great.
In respects to accountability, I agree with Carol. It starts with the individual. But I think also structures that can help us are, for example, the medical record. How is it that we use it appropriately to see, what is it that the patient and the family need? Language services versus how is it that we identify a patient in our medical record? As a matter of fact, yesterday I had a huge aha moment because of Guadalupe. Actually, several staff reached out because we had 3 transgender patients across the network. And when I went into Epic, the first time that I saw this, we identified them female pink and male blue. And we have some other colors as well for those patients that do not want to identify themselves as something else, another sex, but we're not using it. And so how do I take that information now to really then start teaching as to how is it that we use that information so we can empower the staff to really have that cultural competence to be able to treat our patients.
It's a great aha moment.
Yeah, and there's so many ways we can look at our organizations and tell. I mean, we all know, right? We've all have problems to work on, but when we think about certain populations, I know that there's some trends in emergency departments where certain populations are showing up there because XYZ, right? Maybe patients who don't have access to language access services are not able to, coordinate appointments with primary care, and so then end up with, conditions that are emergency level, or they are using emergency room because they don't have a way of getting, to communicate or set up appointments. And so I think, just kind of watching those other trends too. There's, the symptoms that kind of bubble up in various places. And I think that all comes back to, that cultural competence in of the organizations. So, yeah.
I'm going to dig into something related to that. We talked a little bit about patient satisfaction and whatnot, and I work at the Department of Health, and I check these kinds of things, and our hospitals are doing really well. But also as a patient, I know that I don't respond to every link, to every survey. So I kind of wonder, well, yeah, we're hitting 93% on this, but if we're only getting 92% of the population responding, what does that mean? We're reinforcing our blind spots to who we're not serving well by not serving them well.
Absolutely. And patient surveys is a huge thing. I was going to talk about that in a little bit too, but I think it's, worth now, I think because, EHRs we're still in the development phase of sort of linking in the preferred language of our patients, right? So everybody gets the patient survey in English, regardless of your preferred language. So so there's that problem. And then there's also, some of the data on that is limited in what we're tracking. So, the ability to sort of, disaggregate data and sort of find where there's closer trends. There's definitely a lot of room for improvement with patient surveys. And plus we're missing, a lot of qualitative data too, in that what are patients' experience of discrimination and things during that. And so that's a really good point. Patient surveys have a long way to go for sure.
Plus, patient experience is different for everyone. And for example, for my 80-year-old Hispanic mother, it looks very different than perhaps it's even looking for me. For her, it's about, how does a team work together? But for her, it's not about, that people answer the call right away, but rather than, for her, it's more important that her daughters are able to be in the room to help with care. And if she sees that that's not being allowed, then she feels that her patient experience is not such that she would like to recommend.
Mm-hmm. Yeah. Absolutely. Okay. We could stay on this one all day. So we'll stay in a large group discussion, but thinking about policies and collection and use of data. And I'm not going to tell you how important data is because I know you all know that. But in thinking about some of the policies and some of the things that Guadalupe mentioned earlier, obviously our organizations do not have racist, sexist, homophobic policies, but I think I would invite people to think about how are those policies reading? They're not those things, but they're not anti those things. And so when we think about policies, for example, supply chain, purchasing, food service and other supplies for organizations. Do the policies say you should look locally and try to support, BIPOC, LGBTQIA+, women-owned businesses in your own community as a first stop for looking for these things? Because that's really what sort of an anti, policy would look like. So how are we really refocusing our energy on combating those systems and really investing in our own communities, because as we know, community wealth equals community health. We've all heard the saying, the biggest predictor of health is your zip code. Well, that's because of the money that is in the local economy. And so if we're really thinking about, making a difference on those systemic barriers, then how are we making decisions across the board? What do all of the policies look like, and how are they inadvertently reinforcing the systems that are keeping things in a problematic place? So how about some other policies?
I think one of the real basic ones, and I see this as I travel around the country doing these surveys, is basic dress code policies. I think that, what we believed was sort of what the provider is supposed to look like or the caregiver is supposed to look like has really changed as we've welcomed more diverse individuals into our professions. And so when you have a policy that prohibits certain hairstyles or other things, I think it puts that group at a disadvantage because they can't actually belong because the policy prevents them from really belonging. So I think sometimes just looking at some of the things that we've always taken for granted in our organizations and say, does this really make sense anymore? And what message are we giving?
Yeah, there's a lot of stigma around appearance, right? And a good friend of mine talks about how important, hair color is to the queer community and through just expression of that way of different hair colors. And that actually reminds me of a hiring experience I had a couple years ago. I found this superstar person. I was so excited to hire her. And during her interview, she came with brightly colored hair and several facial piercings. And I read the professional appearance policy, and she could have one of those, but not both of those things, and one piercing. So I'm thinking, please, you're not going to tell me I'm going to lose this stellar person because she has piercings, and her work is all phone based too. And so and actually, thankfully, it just so happened that policy was under revision at that current time, and so I was able to kind of squeeze her in. But I mean, I thought if that would have happened 6 months earlier, would I have been told, no, I can't hire this person who is highly qualified and remains a superstar person to this day? But yeah.
So using data to drive action, CMS is actually focusing on this, right? So using outcomes data, I think, is super important. We oftentimes look at tons of data in healthcare, right? We look at readmission rates, we look at the length of stays. Maybe we window it based on the insurer or based on the diagnosis that they have. It's rare that we look at their language status when we're looking at this information, or what is their race and gender. And that's hugely important. We need to start doing those. We need to have our data and our reports and analytics be able to be windowed by SOGI data or by any number of pieces of information so that we can see where we've got big gaps in healthcare and healthcare delivery, because we know they exist, and we need to do things differently in those particular cases to make sure that those readmission rates are addressed in the same way that we would with other folks. So I think there's a ton of work that needs to happen in the way that we look at data to make sure we have the right filters and the right reports that addresses this problem. And it needs to go, not only to bedside clinicians, but also to our C-suite to make sure that we have appropriate buy-in and changes in processes.
Well said. Yeah. Well said. Absolutely. And in thinking about some of that, it's a challenge. We all want to sort of dive in and say, here's what the data tells us. But, what I have found with a few projects in the last few years is that when you do that, you have all these other systems that then you have to actually pivot and advocate with. Epic, the EHR system, we have to be able to have this capability. Oh, wait, we have to look at Workday, our HR system, and now we have to go to corporate HR and start having these conversations if we want to change X, Y, and Z to be able to get what we want. So it's it is a can of worms, and it's a slow process when you have to sort of switch your focus, to all these other systems that are impacting your ability, to get that data for sure. And I think, as hospitals, we also have a great opportunity for a lot of data from our own communities through the Community Health Needs Assessment. I have to put a plug in for that because that's part of the work of my team. And I think it's just a really valuable tool that's been underutilized. We survey everybody in the community. We ask them what their priorities are. And then it gets filed away on, a 100-page paper on a shelf somewhere. And instead of really tapping into that and saying, okay, we asked the community what they wanted. They told us. Now, what are we going to do about it in a meaningful way? How are we going to sort of pivot and use that that information, a lot of it qualitative, but also some different quantitative data as well, and how can we use that to better the organization and really create some energy in the community with our community partners to work together as a system to kind of look at the access issues that came up, the barriers that were part of those findings.
So I work, some of you know, in government community relations and have for a long time, and one of the things that isn't in my job description but I spend a lot of time on is customer service recovery. And I think, in my experience, one of our biggest issues is in our approach to customer service as healthcare organizations. And if I had a magic wand, the list of things I'd want to change is long, but one of them is training everybody in trauma-informed care, because I think we're always making assumptions about the people who are coming before us, our customers. And if we treated folks with more humility and were more humble, I think we would demonstrate our good faith a lot better.
In regards to that also, how is it that we make that link in our electronic health records? I was thinking about your son. And so how is it that we can put a flag or some kind of identification with that patient? So, for example, if your son comes to the clinic, that nurse can perhaps pull him and you, rather than leaving them in the waiting area, or being able to do some things for the patient. Or maybe that patient with dementia that gets violent because they don't have a loved one with them. How is it that we can put that in our medical record to really drive action and care for those patients that cannot speak for themselves?
Well, this makes me think about accessibility and the infrastructure that a lot of hospitals have. And I was at Climate Pledge Arena in Seattle, and they had a sensory room. So I thought a lot about, my younger sister is also autistic, and she gets very overstimulated. So having a sensory room in the waiting room where people can wait and just feel not as overwhelmed before their visit. And then I think people regard disability a lot as someone who is in a wheelchair or can't, is not as mobile, but it looks a lot different. Sometimes, for example, some lights or certain wattage and they cause seizures or something like that. And it's other things to think about with infrastructure. So.
Thank you. Great. Thank you so much. Yeah, those are all really great points. So we're going to get back into our small groups, our table conversations, to talk about the next area, which is inclusive representation in our leadership and our governance structures. So if you want to just kind of reflect on the dimensions of diversity on your boards, the people you hire, the tables that you sit on, the community leadership tables that are maybe around in your community, and really thinking about, what are the consequences of not having inclusive groups that are making decisions and that are leading, a lot of the work in the organization and strategies in our communities, and then something that you can do to address those gaps in diversity. So, okay, 5 minutes. All right, we're going to come back together because I just realized that our time together ends at 3 and not 3:30. So, great. I know. I would have kept you here 30 minutes late. I'm sorry. Okay, so we're going to come back together. Does anybody want to share sort of initial thoughts? I guess particularly in the realm of what are the consequences of a lack of inclusivity at these decision-making tables?
We get to repeat our mistakes again and again if we don't make some changes. But in general, I think that the diversity in Vermont tends to be socioeconomic, and that I'm a board member at Rutland Regional, and I think we have to be careful about having only higher socioeconomic people on boards, but especially in healthcare, because you have a bunch of people making decisions about healthcare that they're not experiencing. So that, Medicaid, Medicare population that really is, at a disadvantage statistically, tells us that we need more exposure to people who maybe don't have the same means to donate to boards, but they have a lot of life experience that could lend a lot of qualitative help in terms of the direction in which healthcare could go. So.
We talked about doing board gap analysis, trying to identify where your blind spots are. being aware that you have blind spots. Looking for people who are different instead of keeping with the same format that you've always had and expecting something different to occur.
Just touching base on sort of the last element of that is that, community collaboration for shared decision making. I think just, really being intentional about the way we're interacting with the community, which groups in the community, if we are investing in the community, how are we investing, with whom are we investing in the community with, which types of organizations. I think, paying attention to fostering the multi-sector collaboration so that we can really start to have these conversations at a systemic level that, are, the financial institutions at the table, are the colleges, are the smaller nonprofits, the larger, making sure that we have sort of well-rounded tables, inclusive of multi-sectors as well, because they all have the power to influence, those different spheres. So really, we all have a role to play as a large healthcare organization, right, with that power to influence, as an employer, as a neighbor and partner, as providers, community partners. I think there's all sorts of questions that I think we can ask ourselves and to really think about the ways in which we can influence, within the ways that we can, all these decision points, right? It's really about all the decision points. And when we get to those decision points, are we thinking about those decisions differently? We have all these ideas of, where do we go from here with all of this information? And of course, one thing that has been mentioned a couple times is doing a gap assessment. And, we don't have to recreate the wheel. There's already defined best practices out there. One that's really great I recommend is the AHA Roadmap to Health Equity. They have like a very clear framework that is easily applicable, and just finding, the best practices for some key areas, kind of like the 6 that we talked about today, and using those as benchmarks to say, where are we on the journey of looking like that? And there's some really great information as part of that roadmap to really get you operationalizing and moving to those places. So also in closing, I guess I would ask you all to reflect on, what would it look like if equity were the starting point for every decision that you were making, on your team, your department, your organization, and how can you tap into your own power, your own networks, your own ways of influencing all of the decisions that are happening around you, and keeping equity as a top priority in a world of many priorities. So thank you so much for coming, and there's, again, just a few resources here to check out that could help you on your journey, and we really appreciate you engaging in this conversation today. I'll hand it over to Emma.